Hi, this is Julie Freischlag, and I'm delighted to be here to host some question and answer period for leading the time of crisis. Joining us today is Dr. Fabrizio Michelassi, who's the Lewis Atterbury Stimson Professor and Chairman of the Department of Surgery at Weill Cornell Medicine, and the Surgeon-in-Chief at the New York Presbyterian Weill Cornell Medical Center in New York City. He's a practicing general and GI surgeon. Also joining us is Dr. Matthew Hutter. He's a general GI laparoscopic and bariatric surgeon at the Massachusetts General Hospital in Boston, where he directs the Codman Center for Clinical Effectiveness in Surgery and the MGH Weight Center, as well as the Quality and Safety Program for the Department of Surgery. He is currently the president of the American Society for Metabolic and Bariatric Surgery, and he's been integral in the development of the NSQIP and the MBS NSQIP since their inceptions. I know Matt well as Fabrizio well, because they've been longstanding faculty for our American College of Surgeons leadership course. And of course, David Hoyt is with us. He's a renowned trauma surgeon who currently serves as the executive director of American College of Surgeons, overseeing the operations of the organization. And we've known each other since 1987, where we both were faculty at UCSD just a few years ago. So I'm going to ask some questions to these amazing speakers who have given you great talks on this time of crisis. And I'll start off with you, Dr. Michelassi. How did you prepare your physicians deployed to new clinical areas when they were not familiar with how to practice in those areas, such as the ICU?
Well, thank you, Dr. Freischlag, for this question. Physicians and healthcare providers were eager to help and play really an incredible role in responding to the crisis of the COVID pandemic. But they were concerned about not being able to provide competent medical care if deployed to an area with which they were not familiar or to tasks that were not familiar. So an example could be, for instance, a senior breast surgeon deployed to an ICU location. That would not work. So first of all, we tried to match faculty skills with faculty deployments. In the case of NICU deployments, we tried to select younger faculty members just fresh out of a general surgery residency and obviously still very competent in ICU care. We then tried to deploy mid-general surgeons, mid-level general surgeons, colorectal surgeons, vascular surgeons, bariatric surgeons to hospital medicine, or be deployed within other areas of the hospital, such as the emergency room and so forth. And for the senior or super specialized surgeons, we deployed them to telemedicine to really be the face of the hospital with the population outside of the hospital, trying to keep non-COVID patients outside of the hospital, outside of the emergency room, but at the same time handling their needs and making sure that they were still part of our mission. All of them were really placed under the supervision of more expert clinicians, and all of them were onboarded with the appropriate education and instruction as a refresher course from the ICU to the telemedicine. And all of them were told that they were not in by themselves. We're all in together. And first rule was to ask for help anytime help was needed. And things went really remarkably well with these principles.
Thank you for sharing that. Dr. Hutter, you set up a field hospital. Can you tell us what lessons you learned and how will that translate to any permanent changes at your institution?
Well, I can't take credit for setting up the whole field hospital. It was an amazing team effort in order to get this done, not only with the city and the state and the military and FEMA, but just being part of that team was certainly something special. And even though it was only up standing for 3 months, and it's right now in warm conversion, and hopefully we won't be back in action, but it's ready and we're ready to go. There were a lot of things that we learned. There was the team with the huddles and the amount of work that we got done so quickly, we didn't skip any steps. We just moved through them with like-minded people with one mission in mind and focused on the problem at hand. And everybody got together. We had these huddles. We made decisions. We made action plans, and we did them. and then we redid them. And this happens several times a day. I would love to do that at our hospital. I mean, when you look at some of the things we've been trying to accomplish for years, and they don't happen. So how do we take that and bring that back to what we're doing now? I can't wait to try.
Great. So Dr. Hoyt, talk about the importance of incident command as a trauma surgeon in your previous life. How did you use it during these kind of situations?
Yeah, thanks for the question. Incident command is a concept that goes back to the U.S. Fire Service in the late 60s and early 70s. And it was really designed as a way when you bring multiple services, fire, police, medical care, et cetera, together, you've got to have some kind of model that recognizes the authority for setting the plan and then using that as a way to oversee and deploy, like what Matt just said, that you know, the same kind of energy that he felt in solving problems and using and working with each other. That's what incident command is designed to do. It works very well, and the way we did it in the college or hospitals did it was to basically bring together all departments. So the resources you might need in a hospital, that's going to be beds, PPE, financial resources, whether you need to build capacity, et cetera. In the college, it was really, how do we bring the expertise together to help surgeons that are trying to solve problems do it at a global level? How do we bring resources either from CMS or DOD or FEMA to hospital areas? How can we help? How could we come up with common ways to advise people to ramp up or ramp down surgery? Those are the kinds of problems we were solving. And then we had our own personal problems. How to deploy our workforce out of downtown Chicago? How do we plan for the financial resources we're going to need to sustain ourselves? So all those elements become the agenda of the incident command, and you decide who's going to be in charge and who's going to listen, and everybody follows that model, and it works very, very well in a disaster or a time when there's a lot of confusion.
And maybe you can comment on that too, Dr. Hutter. You use hospital incident command systems. I know ours was in place longer than ever before, because it was usually weather or something like that where it was a shorter time. This was weeks to months for us. How will this lead to changes in our hospital as we go forward? Can we learn to make quick decisions with good teams all together, even virtually talking to each other for a solution?
Well, I think that's a great question, and I wonder if this format is so effective in that situation, then what are the downsides, or what are the plus sides that we should incorporate into how we're doing things right now? Because we can certainly do things better, and I think we've all had some frustrations, red tape, or other kind of roadblocks that are there. Some of them are, you know, to be thoughtful, to have oversight, to not miss things that can get, you know, if you're too rushed or too urgent, could get overlooked. But I just would love to take that special sauce of what is the hospital incident command, or what we've learned from these situations, and impart that into our future structure. And I would be intrigued to see how people change, because I think people's mindset have changed. Wow, we can do this way. Wow, we can work together. Wow, we did build bridges. We did. Others perhaps not. You know, I've heard of some incident command systems where they're very dictatorial, top down, and didn't have the same kind of situation that David Hoyt and I were just describing. But I think we should take this as a learning opportunity to figure out how to lead better going forward.
Agreed. So Dr. Michelassi, you had a large number of COVID-19 patients in New York. I think over 800 at some period of time. How did you support these physicians and staff that you redeployed and re-educated with their work hours that were extreme uncertainty, the exposure to these critically ill patients, which we are just now sort of understanding what kind of protection we need? How did you do that?
Yeah, it was a challenge because we had the first COVID positive patient admitted on March 7th. We stopped doing elective cases on March 13th. We stopped doing time-sensitive cases on March 20th. And we hit the peak of COVID positive admissions and inpatients on April 20th. Before I give you the number, you have to understand the New York Presbyterian Hospital is a conglomerate of 10 hospitals with about 2,900 adult medical surgical patients. Out of 2,900, 2,550 had COVID positive patients. So 86% of our capacity. And we have 400 ICUs. We had 850 patients in ICUs. We made ICUs out of operating rooms, recovery rooms, any space that could lend itself to that. And between March 7th and April 12th, we knew that the day after was going to be more challenging than the day before. And so we provided support to all the healthcare providers, whether they were staff, physicians, residents, for physical needs, first of all, including access to healthy meals, hydration while working, in-hospital rest areas, lodging for individuals who lived so far away that it was not possible to go back and forth, or wanted to live away from their family for the fear of bringing COVID-19 back home. Transportation to and from different boroughs for individuals who wanted to go back to their families, assistance with childcare needs. We also, and this was very important, provided support for emotional and psychological needs, including psychological first aid, deployed via webinars and conferences, and most important, directly to each unit and each single provider for those with greater distress. And I have to say that it was successful. I also have to really echo what Matt said. The level of energy and enthusiasm almost, and the sense of, yes, we can do it, that I experienced in that month from March 7th to April 12th was incredible. And the things that we did, the many decisions that we made, most of them quick, and fortunately, most of them, if not all, appropriate, was really very rewarding.
That's great. Well, we thought that the American College of Surgeons, Dr. Hoyt, did a great job with the information that was provided to all of us. How did you interact with these national organizations, government, DOD, FEMA, and others? And what did the American College of Surgeons contribute? And as you looked at financial solvency too with that, you had to make financial adjustments like all of us did during the time of being very busy, learning how to cut back your costs.
Yeah, thanks, Julie. One of the first things we did was decide that communication was going to be very important, not just to our staff and to our constituents, but to really use the common resources that the college can garner by exploiting the expertise of our members, and use that to come to consensus about a problem that they were all facing, whether it was PPE or which patients should be delayed surgically, which patients could be restarted when we restarted. So all those were decisions that we convened a group to try and help solve, and then tried to communicate that. So we decided very early on to take all of our communication resources and suspend them. So the bulletin, the news scope, and all of that was basically put on hold. And we created basically in 48 hours a newsletter that was designed to be a source of truth. Started publishing that twice a week. We created an editorial committee, which is a little different than the way we do it. We had regents and officers involved. Dr. Michelassi was actually intended to be a part of it. He was so busy at home, he couldn't. But the idea was we were aiming everything we were creating at somebody like Dr. Michelassi, who was in the middle of it, and what could we do to help scale that? On the financial side, I personally learned a lot. I think we all did. We've all been in financial planning for decades, but what I learned is the way to use what financial people do to model for a worst case scenario contingencies. And so by going through that actively, we were able to predict whether we needed to furlough people, whether it was likely we would have to have people lose their jobs. And the good news is we did not. We were able to look at the impact on our revenue sources and our expenditures. And at least within the college's budget, we were able to go forward for several months with the assurance, get back to work. We're gonna get through this, and don't worry about your job. And I know that hospitals did the same. So I think that's a skill that we've all learned as well.
Right. And I think what I would just echo is communication is key. You know, telling the truth. We actually mimicked exactly what the college did. We sent out something every day, which was the COVID-19 sheet, so people knew what was going on, how many cases were there. We didn't have the number of cases Fabrizio did, but we were waiting. And that actually, for some of us, was even harder. You waited and waited. You weren't doing anything, and you waited some more. So that was tough as well, too. But that daily communication, we did videos. I know I did a video for the college. We did them locally as well, too. And then also being able to say you don't know. I think that was hard. You don't know what's going to happen. Every patient was different, that we didn't know exactly how to come back. And I think we're still on that journey, right? Trying to get to the other side, and whether it's going to be months or a longer period of time, we'll have to wait to see. But I learned a lot about communication and also the resilience of people, right? And their grit and their ability to go forward just in the light of taking care of people. Any final comments, Dr. Hutter?
No, Dr. Freischlag, thank you very much for having us all together for this session here today. I feel a little bit funny. Here you are, who running a whole, the CEO of a health system and the dean of the medical school. I would love to hear a little bit, if you don't mind, about what you learned, the lessons you learned about either the incident command or from anything from this whole crisis we've been going through.
Well, what I learned is that you have to use everyone possible, as all of you did for clinical. We had to let our students go home, right? Our third and fourth year, mainly because of PPE. We had to disband all research, right? Because they did research right next to each other. And so making the research turn off and then turn back on was tough too. Who's going to take care of the animal care? Who's going to take care of the laboratories to make that happen? And then at the same time, giving people hope, even though you weren't quite sure what the duration of time was going to be. So we held a lot of teleconferences. I guess we all have learned to WebEx beyond belief now to do it, or Zoom, to make sure the students knew what was going on, make sure that there were ample opportunities to ask questions to make that happen, and presence. I'm sure all of you were present. We saw Dr. Hoyt online. I'm sure you were present too, Dr. Michelassi, and you too, Dr. Hutter. I walked around. We have a daily safety check. I ran it every other day, so they saw me stop operating, saw me start operating, they saw me down in the ED and the incident command. So part of it, I think, is that presence, that concern and caring, and then making sure that there is hope, even though you're not quite sure where you're going. I've never quite been on a boat where I didn't know where it was going. You know, if you do a ruptured aneurysm, you know there's a couple opportunities that's going to happen, right? But this, I wasn't quite sure if we were going to put in a graft, whether it was going to bleed out or whether it was really a ruptured aneurysm, right? So with this, I think the unknown is what it taught me to learn how to lead without knowing. And even now, in the next 6 to 12 to 18 months, how do we go forward to take care of our patients? How do we take care of each other? And then how do we get back to, we're calling it the new way, not the new normal, because none of us were ever normal, but the new way. And I'm sure you too, Dr. Michelassi, are doing exactly that, trying to get on the other side of this, which I know New York, you still have quite a few patients in your hospital. Any other comments, Dr. Michelassi?
Well, we call it, you're right, we call it the renew. We don't call it the restart. It's the renew. I think we have learned a lot of things. The most obvious is that telemedicine is going to be with us for a long time, for patient satisfaction and for us being able to be in contact with patients. So it's a renew. And I think that as we talk, our heart goes to the part of the country that are experiencing now what we experienced 3 months ago in New York City. I know it's tough. And also our thoughts go to the future, because the post-peak is probably as challenging, and it probably even more so than the pre-peak, when the patients obviously need to stay in the hospital and for a long time, and at the same time, obviously the healthcare system wants to gear again to take care of also non-COVID patients. And in some situations, the non-COVID patients have been, the care of them have been postponed for some time. So it's a challenging post-peak time also that we need to think about and get ready for.
So final words for you, Dr. Hoyt. We just have a few seconds left.
Thanks, Julie, and thanks to all of you as colleagues. I think the thing that I'm most impressed with coming out of this is the extraordinary leadership that surgeons have provided to their colleagues in their institutions, as just evidenced by this last hour. And I hope we can keep that going, because that's what our patients depend upon. And I think surgeons of all physicians are the most up to it.
All right, well, thank you all. And I thoroughly enjoyed your talks as well as this discussion. Thanks so much.
Thank you, Julie.